Greetings, everyone. This is Mehl-Madrona, affiliated with the University of Maine at Orono in the United States, and also with Wabanaki Public Health and Wellness in Bangor, Maine, and the Coyote Institute in Orono, Maine. I'm here today to talk to you about modeling the appearance and course of cognitive impairment with implications for prevention. And I have nothing to disclose, and I want to also acknowledge that I'm speaking to you from the unceded territory of the Penobscot Nation, and I wish to acknowledge their elders, past, present, and future. And so nothing to disclose, as I mentioned. So what we're endeavoring to do in our research program is to predict the development of cognitive impairment using a systems dynamics computer simulation model. And perhaps more importantly, to predict what people can do to delay the onset of cognitive impairment or even potentially to reverse it. And so an important concept to this is that of cognitive reserve, which grew out of the observation that there can be discrepancies between the amount of neuropathology present in the brain and the degree of cognitive or functional impairment among individuals. And recently, the Alzheimer's Association has defined cognitive reserve as adaptability that helps to explain differential susceptibility of cognitive abilities or day-to-day functioning to brain aging pathology or insult. And what this takes into account is one's lifetime of experience in combination or interaction with genetic factors that enable the cognitive processes to be resilient. And these experiences can include educational and occupational attainment, general cognitive ability or intelligence, and engagement in activities that are cognitively, socially, and physically stimulating. So cognitive reserve is differentiated from brain reserve. Brain reserve refers to the structural characteristics of the brain at a given point of time, which is also important. A related concept is brain maintenance, which refers to the process of maintaining or perhaps enhancing the brain through lifetime experiences and their interaction with genetic factors. And this is what interests us the most. The primary treatment strategies for dementia include prevention, slowing or halting the progression of illness, and reversing symptoms. And so we're attempting to build a model that can do all that. And so what matters? What's important? What needs to be in such a computer simulation model? Well, exercise is one. We know that exercise improves performance of activities of daily living. It reduces falls and fall-associated injuries. It improves physical function and cognition, and it decreases mortality. Also important is engagement in cognitive activities, which delays the onset of cognitive impairment. Cognitive stimulation provides lasting benefits for continued reasoning ability and maintenance of activities of daily living. Socialization matters. Women with wider social networks had a lower incidence of dementia than their less well-connected sisters in a study by Crooks et al. Friends are actually more important than family, according to Sharifian et al. From Aging and Mental Health 2020. So a greater proportion of family in one's network is associated with lower contact frequency with friends, and in turn, lower memory. Higher contact frequency with family was not associated with improved memory, but higher contact frequency with friends was. Diet matters. High sugar and carbohydrate diet increases progression to dementia. High caloric intake is associated with cognitive impairment, and the Mediterranean diet is associated with the lower incidence of impairment. In Japan, Ozawa et al. Found that soybeans and soybean products, vegetables, fruit, algae, and milk and dairy products, and a low intake of rice was associated with reduced risk of dementia, whereas the Western high-fat diet with red and processed meats, refined grains, sweets, and desserts contributes to the development of dementia. And now I want to talk a little bit about our excitement about Bredesen's work. Dale Bredesen from the University of California at Los Angeles and the Buck Institute for Research on Aging in Novato, California, USA. So Bredesen in 2014 published an inspirational case series of 10 patients who were able to reverse dementia. Well, 9 of the 10 were able to reverse dementia. And as a proof of concept study, this was very exciting because it showed that it was possible. And many of us did not believe that it was possible before this paper. So the one patient who was unsuccessful was a very late stage Alzheimer's patient. 6 of the patients who had to discontinue working or were struggling with their jobs at the time of presentation were able to return to work or to continue working with improved performance. And those improvements were sustained at 2.5 years follow-up from the onset of treatment. Now we'll speak briefly about Bredesen's treatment, but one can enter his name into Scholar Google and read his papers. But the notion is that he is attempting to address all of the factors that may be important and not just one at a time. And he says that the relative failure of monotherapeutics for dementia to date raises the possibility that a multiple component therapeutic system is what is needed. And he went on to publish a paper with colleagues in 2018 of 100 patients who had used his protocol. And they reported on these patients who were treated by different physicians with better documentation of improvement using imagery and laboratory studies and neuropsychological testing, as well as subjective report and the report of relatives. And so their attention was a precision medicine approach that involved looking at reducing inflammation, reducing intestinal permeability, which of course leads to inflammation, reducing negative effects of trophic or hormonal agents, eliminating toxins, and increasing the quality of diet, the amount of exercise, reducing stress, and other factors. So they talk about, Bredesen's group talks about how treatment typically fails for dementia because it's initiated late in the pathophysiological process, and that Alzheimer's disease is not a single disease, and many things contribute. So I'm going to go on to examples of interventions include identifying and treating pathogens such as Borrelia, Babesia, or herpes family viruses, identifying gastrointestinal hyperpermeability, repairing the gut and enhancing the microbiome, reducing insulin resistance, providing improved nutrition, hormonal and trophic support, and reducing toxins. So a quick case example from Bredesen, a 73-year-old female physician with a history of memory decline and word-finding problems that began insidiously for 20 years previously, but had accelerated over the past year, leading to her significant other describing her memory as disastrous. She could not remember recent conversations, plays she had seen, books she had read, and mixed up the names of people and pets. She had trouble navigating her way back from the restroom to her restaurant table. The PET scan showed decreased glucose utilization in the anterior superior precuneus bilaterally, as well as the anterolateral left temporal lobe. MRI revealed biparietal atrophy with decreased hippocampal volume to the 16th percentile for age. Neuropsychological testing placed her at the 9th percentile in cognitive functioning for her age. She was treated with Bredesen's protocol, and over 12 months, her neuropsychological assessment improved to 97th percentile in cognitive function for her age. Her hippocampus increased in size, and her PET scan improved. Her significant other said that her memory had improved from disastrous to just plain lousy to finally normal. So Bredesen's protocol is intensive and complicated for average patients to follow, but it should inspire us to work multifactorially and to look at multiple factors that can contribute to improvement. And now I want to talk about our computer simulation model that we're still developing and would love to correspond with others about. And my email address is louis.mehl-madrona, no dash, at maine.edu, and I would be happy to hear from people. So currently our model includes exposures to medications that can lead to dementia, such as Z drugs and benzodiazepines, family history, social isolation, hemoglobin A1C, BMI, education, quality of social network, meditation, quality of diet, cognitive stimulation, multi-generational living. And we have a prediction of severe cognitive impairment by age 78 of a patient following a typical Western lifestyle, which was accurate. And we have a prediction of a patient who improved using the Bredesen protocol, which was accurate. And we have our intervening variable, which is cognitive reserve, which is affected by a variety of factors. And so difficult to tell you about the model in such a short period of time, but I'd love to correspond with people. We have a prediction that shows low family history versus high family history, and the difference being dementia onset in the early 60s versus not at all, with everything else staying equal. So that's all for now. And I encourage you to connect with me. My 15 minutes is up, and I thank you for your attention. And I thank the conference organizers for the opportunity to present at this conference.